So, um, I was going to ask a few more questions if that was okay about TDI. Would that be a problem? Because I was just
No,
thinking about.
let me explain something to you so you understand.
Sure.
When I started in 1976, the parent corporation was called Cherry Hill Medical Associates.
Okay.
And it was a medical practice for all kinds of medical things. And it took care of motor vehicle accidents and nursing home patients and hospital and all that stuff. TDI, thermographic diagnostic imaging, came about in 1982 when we started doing infrared imaging.
Okay.
Health through awareness, which was an offshoot of that, as I explained last night, came about around 2001 or 2002. So there's actually a fourth corporation called Chronic Pain Consultants, and it's all been subdivided mostly so that people understood, well, Cherry Hill Medical was for coughs and colds, and TDI was for thermograms, and Health Through Awareness was for diet and lifestyle changes, and chronic pain was for the RSD cases.
Okay.
But it's all me.
Right.
So you can ask any question you want. That's subdivision.
How would you like me to ask you then? Like, should I say, was it Cherry Hill?
What's the question?
Well, okay, so I was going to ask, you also at TDI, you also teach patients therapeutic lifestyle changes. What health conditions is this recommended for the primary treatment? Does that make sense? All right. What health could...
Really, the answer is that when we talk about a background, then I'll kind of fast forward over what I just explained and how it all came to pass, and that'll be, I think that'll probably be the best way to do it. And then you can ask any question you want as an offshoot of that.
Okay, yeah. I was just going to ask, like, at Health Through Awareness, you put emphasis on knowledge to make informed decisions regarding what. And then you're certified in biopuncture. What is biopuncture, and who would you suggest getting this treatment? Is that okay does that make sense for you?
Sure.
Okay, cool. Yeah, because, well, there's a lot of people that are going to be calling in tonight, so I don't know how long this will run, and I just let everybody know that we don't have a time limit, so they're super excited about that. And I heard we have a bunch of listening parties, so maybe it was a blessing in disguise that it didn't, work last night, because there's going to be a lot more people listening in. And I did tell them that you said that, you want people to call in and ask questions, so they'll be doing that. Also through my YouTube.
Yeah, and if for some reason, because the question is going through you to me, if I don't hear it, I'll just simply ask you to repeat the question for me.
Okay, I'll do that. Then also on the YouTube Live, I get comments, and because I see people right now, Barbie from Ipine just said hello. So I'll be able to see questions and comments on there that I'll be able to ask too if somebody doesn't want to call in.
That's fine. Tell Barbie I owe her a phone call. I'll talk to her before the end of the week.
Okay, I will. I think I told her that before. Hey, Brian, quick thing. Where do I go back and forth on this? Do I go to Live Dash or do I go to call hosting session to see who's calling in?
Yeah, if you go to the call hosting session, you can see who's calling, and then you just go to the other one, and you can see your question.
Dr. Getson, would you mind then if we did take a minute break to have a quick
drink?
Well, yeah, I usually have a sip of something, but...
It's your show, any way you want to do it.
Okay, well then around 30 minutes we'll be taking a minute and a half break, just from a word from our sponsor, and... Yeah, the reason why we wanted to do the full thing is because the archive shows, we need the whole show on there, and we don't split it up. So that's why we'll be asking things again.
Yeah, and you know what? Send me the archive, and I'm familiar, but this is why we're doing it.
Okay, I could do that. I'll say that right in the beginning.
I'm probably going to say, some of the same things I said last night. So for those who listened in last night, well, okay, you'll hear the same story second time, but bear with us.
Okay, I'll do that. I'm writing it down now. Yeah. Let's see.
Yeah, I mean, it's some of this. Obviously, you never tell the same story exactly the same way twice, but the are about the same.
Well, and there's going to be a lot more people listening in tonight too, so they'll get to hear it. What was that?
That was me.
Okay.
Shutting something down.
Okay, cool. All right, great.
We're getting ready to come up here and get things started here.
Okay, yeah. So you're going to be
about coming up on. About 45 seconds.
Okay. Yeah, you heard Brian. That's my fiance, by the way. In 45 seconds, we'll be going in and the music will start. And then I'll come on and just do what I did last night.
Fair enough. I'm ready to roll.
Thank you.
And
you're welcome.
And make sure he knows that it'll be quiet. He won't hear anything.
No, he knows that already.
Okay.
It was last night. Okay. Do you have me on?
Yeah, you're on.
Okay, cool. All right. What do I have to say? Yes.
We got about 15 seconds here.
Okay.
All right, your mic's going mute. Got something to say? Get in on the conversation at 415-915-2291. That's 415-915-CALL-1.
Welcome to Conspiracies Against Wellness with your host, Janelle Elgaway.
Good evening. Welcome to Conspiracies Against Wellness. I'm your host, Janelle Elgaway. If you have a question for our guest tonight, we will be taking calls all through the show tonight. The number is 415-915-2291. We are also streaming live through YouTube. If you go to our website, at the top, click on radio and click here. I will be able to read your questions and comments. This is a redo show from last night, so we will be starting from the beginning, and I will be asking the same questions in the beginning. And now for tonight's show. Ready for this one, Call Nation? It's so important to raise awareness on complex regional pain syndrome, or CRPS RSD, which is why I wanted to have 2 weeks worth of the shows on this subject. Next Tuesday, Sherry New will be our guest to talk about the amazing advocacy work she continues to do for the CRPS community and her personal journey having CRPS. Tonight, I am honored to introduce our guest, Dr. Phillip Getson. He is a general practitioner based out of New Jersey and one of the world's leading specialists concerning CRPS RSD. Dr. Getson, welcome to Conspiracies Against Wellness. How are you this evening?
I'm great. Thank you very much for the invitation. I'm really looking forward to getting through the whole thing tonight.
Absolutely. So are we. Can you please tell me a little bit about who you are and what is your background in?
I've been a medical doctor and osteopathic physician since 1976. And in private practice, always in New Jersey. I started out as a general practitioner doing what general practitioners do. Did a lot of work with motor vehicle accident patients and varied my treatment regimen for different people and different things. And then about 1985, 86, I had a patient come into my office one day who had this constellation of symptoms with pain and burning and a lot of things that were kind of curious to me. I'm a mystery buff. I'm a Sherlock Holmes fanatic. And so this was great for me. I mean, I have this mystery. I've got to solve this mystery. So I did what general practitioners do. I sent her to neurology, neurosurgery, orthopedics, pain management, physiatry. And 6 months later, she came back and I had all these reports, and I knew exactly what wasn't wrong with her, but I still had no idea what was wrong with her, and I wasn't going to let it go at that point in time. So remember now, in the mid-'80s, we had antique kind of computers, but we had no internet. We had Dewey Decimal card systems in libraries. So venturing out one day with a pocket full of dimes and the intent to find out what was wrong, I went to the medical library, spent a day and a half until I finally found a reference to causalgia, and started making photocopies of reports and articles. And at the end of a day and a half, I went home, and I was very self-satisfied because I'd solved the mystery. Called the patient the following day, and I said, do I have some good news and some bad news? And she said, well, what's that? I said, well, the good news is I know what's wrong with you. And she said, what's the bad news? I said, I have no idea what to do with it. So I began a journey at that point in time to find physicians who could help me. I wound up meeting physicians from different parts of the country. I actually wound up meeting Dr. Schwartzman, who became my mentor until he retired 3 years ago. And the interesting thing was we met in Florida at a conference, and he was 20 minutes from my office, and I had to go to Florida to meet up with him. But I began to study and research what we then called reflex sympathetic dystrophy. And one person became 2, became 4, became 8, and now it's almost 32 years later. And my best estimate is in the last 15 years, I've seen about 1,300 people that were suspected of or actually had complex regional pain syndrome, reflex sympathetic dystrophy, and it occupies about 2/3 to 3/4 of my day now in my practice.
You founded your practice called TDI, or Thermographic Diagnostic Imaging Health Through Awareness. What treatments do you offer? And by the way, before we came on, you mentioned that you have several branches of practices. Maybe you could explain that as well.
I started out with something called Cherry Hill Medical Associates, which was the general practice back when I started in the late 70s. And in 1982, I got involved in doing thermographic testing. Now, for those who are listening who have never heard of thermographic testing or infrared imaging, it is exactly that. It is the use of infrared, which is non-contact, non-radiologic, non-painful, and it uses infrared to make an image of different things. Most infrared today is being used for breast disease, and as I said to you before, we could probably spend an hour talking about the use of thermography for the early detection of diseases of the breast. But I started out using it for neuromuscular purposes in 1982, and when I got involved in the reflex sympathetic dystrophy portion of my practice, I realized it was clearly the best test to determine whether somebody had sympathetic dysfunction, because it's the only test that we have anywhere in the world that measures sensory and sympathetic dysfunction. So I'm able to look at patients using infrared and non-contact and literally confirm or make a diagnosis of complex regional pain syndrome using infrared. Well, from that grew out Health Through Awareness, which was the brainchild of my wife, Leisha, who is a Reiki master, who is a graduate of the Institute for Integrative Nutrition in New York, and who has gotten involved in counseling people as to proper diet and lifestyle changes so that we can use the simplest modality, which is you are what you eat, to get people better as a part of our treatment regimen. So in addition to counseling and, as I said, Reiki, which is energy healing, and lifestyle changes, we have grown into a situation where there's monthly webinars that come through Health Through Awareness. And the webinars touch on all kinds of healthy living things, from dental to there's about 36 of them on a website right now, so that people can go into YouTube and look at them and get educated free of charge. So we've kind of expanded it exponentially into different things. And then we formed a corporation called Chronic Pain Consultants, specifically for patients with complex regional pain syndrome, which is really kind of dedicated to the treatment that isn't a part of the Health Through Awareness wing.
That's wonderful. At TDI, you also teach patients therapeutic lifestyle changes. What health conditions is this recommended for primary treatment?
Well, we offer lifestyle changes and dietary counseling for anybody. Mm-hmm. You know, somebody can come in and have diabetes, hypertension, elevated cholesterol, and of course a number of people with chronic pain. We have women who thermographically have breast disease, but don't have breast cancer. They just have malfunctioning breasts. So what we're doing is we're explaining to people that how you eat and how you live largely determines how well you are. So we're using diet and lifestyle changes and trying to get people to recognize that the food we're eating today is not the same food that we were eating 30, 60, 90 years ago. And you really have to look carefully and make adjustments in your dietary choices to maintain an optimal level of health.
Why do you think doctors aren't teaching patients this more? Because you go into the doctor's office.
Takes time.
Yeah.
It takes time. And remember now, we're sort of governed by not only the government, but the insurance industry and the pharmaceutical industry. And so they're saying, well, you've got X number of minutes to see that patient because you've got to see the patient, examine the patient, make sure you put the information into a computer, and get on to the next person. And this has caused there to be group practices where there used to be a lot of individual practices. Quite frankly, I don't know anyone other than myself who's in an individual practice at this point in time. So you're constrained. You've got 10 minutes. So how much can you tell somebody in 10 minutes or 15 minutes or whatever the time being? So what we've done here, in addition to the fact that I'm by myself, so I do what I want to do, I have people such as my wife who does this, and I can say, all right, listen, I can't take the time today to explain this to you, but I have somebody in the office who can. And I think that we are a society of Western medical practitioners who treat people, and I say this to patients all the time. In Western medicine, your goal is to make people unsick. And in Eastern medicine, in ancient Chinese medicine, the goal was to keep people well. I mean, it's really 90 degrees from one side to the other. So when people come into the office, most times they're coming in because they have a disease that they don't want to get worse, whether it's hypertension, again, or diabetes or whatever, or they're sick and want to make better. They don't want to. Western medicine isn't geared to, hey, this is the way you have to live so that you won't come back here with recurrent ear infections, so you won't get 4 or 5 upper respiratory infections a year. But that takes time, and it takes a mindset that most Western physicians don't have, which is, by the way, why we have whole upsurgence of integrative medicine and people who are trying to practice more holistically.
That's awesome. At Health Through Awareness, you put an emphasis on knowledge to make informed decisions regarding what?
Health.
Health, okay. Like, but like diabetes, like, is there...
That's how we came up with the name. If you know what you're supposed to do, then it's up to you to do it.
Right.
But most people don't know. So how can you be expected to do what you don't know?
Right. You're certified in biopuncture. What is biopuncture, and who would you suggest getting this treatment?
Biopuncture is the use of homeopathic products to do injections. I'll give you an example. A person goes into the doctor's office with knee pain, so the orthopedic surgeon will inject cortisone and Novocaine into the knee. A biopuncturist would use a homeopathic product, which is, of course, more natural and something that the body is more likely to absorb rather than reject, and it has much less side effect because it is all natural. So the biopuncture is an art form, basically, that homeopaths use and some non-homeopaths use. I use a lot of homeopathic injections for people with occipital nerve headaches, people who think they have migraines, but it really is head pain coming from the back of the head. And I have found that when you use homeopathics, it works brilliantly without the side effects of the cortisone and Novocaine and lasts longer. I do it sometimes, sometimes in shoulders or wrists, sometimes in trigger points, because there's no downside to it. If for some reason they don't get an optimal relief, I can bring them back next week and do it again. I don't have to worry about overloading them with a chemical that their body may not like.
There was a 10-year court battle you won when presenting to the Supreme Court. What was this battle, and why was it so important that you won this?
One of my absolute favorite stories. In 1982, we started doing thermography, and we did a lot of thermography on patients who were involved in motor vehicle accidents in the state of New Jersey. And I need to make sure your listeners understand it wasn't the United States Supreme Court, it was the New Jersey Supreme Court, but the Supreme Court nonetheless. So we petitioned the insurer at that time to be paid for our services, and the insurance company said, we're not going to pay you because we don't think it's what we call reasonable and necessary. And I was very fortunate at that time to have a friend who was an attorney who believed in what we were doing and was willing to represent me on a contingency that if we won, he would take a fee, and if we didn't, he would really do it for nothing. So we went into court in Camden, New Jersey, and we spent the better part of 8 weeks in court. About 4 days a week we would go to court, and then I would go to the office and see patients afterward. And some of my colleagues who were doing thermography around the country were fortunate and kind enough to come into New Jersey on their own expense and testify. And we had experts from really all around the country come in, and of course the people that we sued, 2 little tiny insurance companies called Allstate and State Farm. We also sued the state of New Jersey. Well, they brought their experts in from different places, and we went back and forth for the better part of, as I said, 8 weeks. At the end of 8 weeks, it was determined that we had met the burden of proof, and we won, but the insurance companies decided they weren't going to let it go at that, so it went to the appellate division. It took about another 15 months or 2 years. The appellate division said the same thing, and so they then appealed it again, and we wound up at the Supreme Court of the state of New Jersey. The two insurers, they fired their counsels, the local counsels, and they brought in House counsel from Indiana and Illinois, where the main offices are. And the visual here is terrific because I walked in and I was this general practitioner, and I was on an off-the-rack Today's Man suit, and my lawyer, he had this fondness for his law school briefcase, which was all battered and torn. And if anybody's ever seen the movie The Verdict with Paul Newman, you get the idea of what it was like for the little guys to go up against the big guys. And so Allstate's lawyers come in and they're dressed to the nines, and State Farm's lawyers come in and they're dressed the same way. Their suits probably cost $5,000 or $10,000. You know, the fancy briefcases and all this. And Supreme Court justices, 5 of them walk in and sit down, and it's really awe-inspiring when you see it. And Allstate's lawyer stands up, buttons his jacket, flashes his sleeves, and never got a word out of his mouth. Supreme Court Chief Justice looked at them and said, "We've reviewed the documents," pointed to me and said, "They win, you lose, sit down, we're done." Well, the significance of this is in the state of New Jersey, when the Supreme Court makes a ruling like that, it's law. It is the same kind of law that governs speeding, jaywalking, running a stop sign, whatever. And we were the first state in America we may still be the only state where it is a law that says that in a patient with reflex sympathetic dystrophy, complex regional pain syndrome, who either has disease or expected disease, the insurance company must pay for the thermographic testing when it's ordered, because we spent all these years, going through the battle to do this. And that became the hallmark case for the entire United States, because when insurance companies didn't pay for thermography for neuromuscular reasons, they wound up saying, "Well, hey, this has already been litigated. We're not going to reinvent the wheel. We've done this already once in New Jersey." So the importance was it had actually national scope ramifications. We had no idea this was going to be the case when we started in the 80s, but over the long run, that's what's happened with it. So I think that it's something I'm very proud of, that we persevered for all this time. But I think it just goes to show that if you can persevere more times than not, if you really believe in a cause, and it's helped a lot of people. It's helped a lot of people understand what's wrong with them, because when you look at the pictures, when people have been telling you, there's nothing wrong with you, or it's all in your head, or I can't figure it out, and you put those pictures in front of somebody, invariably that somebody is going to sit and cry, not because they're unhappy, but because somebody finally believes them, and somebody finally recognizes what's going on.
Are there other doctors that use thermography?
Yeah, there's about 300 thermographers around the country, most of whom look at thermography for breast disease, and unfortunately very few of whom look at it for neuromuscular reasons, but we're out there.
All right. How do you currently refer to CRPS RSD, and why has the name changed so many times throughout the years?
Well, there's two questions. To me, having done this for as long as I've done it, it's still reflex sympathetic dystrophy. When I give lectures, I drive the RSD Association crazy, because half the time I call it one thing and half the time I call it the other thing. Now, again, for your audience, and I'm sure most of them are educated and understand that there are different terminologies, let me just explain the following. Complex regional pain syndrome was the invention or creation of the International Association for the Study of Pain, the IASP, who decided that the term reflex sympathetic dystrophy was a little confusing. So they decided to call it complex regional pain syndrome and subdivided it into 3 subdivisions. One, CRPS 1, where you could not identify a nerve injury as the cause for the problem, and CRPS 2, which was the old causalgia, which involved the nerve injury. Unfortunately, it gets a little blurry, because if somebody puts a needle into the arm to draw blood but accidentally hits a nerve, is that CRPS 1 or CRPS 2? The good news is that you treat them the same way by and large. Not 100%, but by and large. So the terminology becomes really more doctor-driven than the real world. There is, as I told you last evening, something called CRPS NOS, or not otherwise specified, where the complex regional pain syndrome actually partially meets the criteria, but they're not 100% sure that it does, and that's the 3rd classification. But quite frankly, I've never seen it.
I never even heard of that. I'm
still calling it reflex sympathetic dystrophy, but In actuality, if you want to really be proper, you call it complex regional pain syndrome, and then type 1 or type 2 is the subdivision. And the classification in the International Association, or the ICD, the International Classification of Disease book that the government puts out for coding purposes, it's no longer in there as reflex sympathetic dystrophy. It's in there as complex regional pain syndrome with all the subtypes. Now, the answer to the second question is the nomenclature. There's so many names. The most common other names, other than reflex sympathetic dystrophy, causalgia, which goes back to the Civil War, Sudeck's atrophy, shoulder-hand syndrome, reflex neurovascular dystrophy, and 10 or 12 others. But it falls into the category of all names that it has been throughout the years. It was actually first called causalgia in the Civil War. It was called reflex sympathetic dystrophy in 1946, and now we're calling it complex regional pain syndrome.
Well, and as I said last night, I'm sure it's going to be named a few different things in the future, just to confuse us all.
Yeah, I'm sure they're going to call it something else when there's people that work for the government that have nothing better to do will decide to call it something else.
Pretty much. Is CRPS RSD an autoimmune disease? Last week, Barbie Engel said that it's not considered a disease, and if it's not one, why isn't this considered a disease yet?
Barbie's one of my favorite people, as you know from my conversation, and does a tremendous amount of awareness work for different pain groups, including reflex sympathetic dystrophy, complex regional pain syndrome. But I think it's an autoimmune disease. It's certainly a disease, simply because those government people we were referring to a moment ago, that international coding book, that everybody, it's the Bible. I mean, you can't get paid if you don't put a code on something. And that's a disease classification book, and they call it a disease, complex regional pain syndrome. So in a technical sense, it has to be a disease. Some people call it a disorder. Some people call it a condition. I think we're into semantics. Most people say disease because they think it has a different connotation. So if you're more comfortable calling it a disorder or symptom complex, but I think it's a disease, and it's an inflammatory disease, and I really think it's an autoimmune disease to some degree.
We just got a comment from Facebook Live. Is RSD always fatal?
I've had 3 deaths from reflex sympathetic dystrophy, 2 of whom were suicides. And the third one, to this day, I can't honestly tell you that the lady died from reflex sympathetic dystrophy because she had so many other conditions. She died from heart-related disease, but I can't honestly tell you that she did or did not have some of the heart problems from the disease. So I would say it's virtually never fatal.
Okay. What is the significance of CRPS upgraded to a disease status?
I think it gives it a little bit more credibility. Unfortunately, we have physicians out there who say it doesn't exist. There are some who said it's all in your head. There are some who call it a psychiatric disease. Physicians, we don't get a course in medical schools which tells us that we have to know everything, nor do we get a course that that doesn't allow you to say, I don't know. An interesting sidebar, the very first lecture I ever gave on complex regional pain syndrome in the 1990s, the very first 3 words out of my mouth at the lecture in front of the group of patients was, I don't know. But you're allowed to say, I don't know. And so many physicians feel that they have to know everything, that if there's something wrong with somebody and they don't know what it is, they're either going to misdiagnose this or they're going to say to people, well, there's really nothing wrong with you because the MRI is normal, the EMG is normal, the X-ray is normal. Well, that doesn't mean there's nothing wrong with you. It just means you have made a diagnosis. So I think that calling it a disease and having it out there in the open a little bit more allows a little bit more credibility, and it forces some doctors to say, just because I don't know, maybe somebody does. And when I give lectures to doctors, one of the things I hope that they take away is if you don't know what's wrong with somebody, get them to somebody who may. Because if you do that, you're doing the patient as much good as if you had the answer, because you're doing them no good whatsoever by treating the wrong thing.
We got another question. Does Medicaid provide compensation for this on a state level and federal level?
I don't know what they mean by compensation, but Medicare pays me when someone comes into the office for a visit or for some of the procedures that we do. So anything that is compensable under Medicare for every other condition. Now, for example, Medicare a lot of times doesn't pay for trigger point injections. So if you have a condition where the muscles get inflamed and Medicare doesn't pay for trigger points, then they don't pay for them trigger points in CRPS patients. But just because somebody has a diagnosis of complex regional pain syndrome does not stop Medicare from paying for them.
Another question from Thea Barnes. What would Dr. Getson like to see patients asking their doctors?
Oh, boy, there's a loaded question. One of the great things about questions is you can't prepare for them, and I love it. I think if you're going to a doctor, I think there's two answers. I think if you're going to a doctor who you've been referred to, who is a quote-unquote expert, I think the very first question that you ask is, how many patients a day, week, month have you seen with CRPS? Because some people will say, well, I see a couple a year, and that person is not an expert. And by the way, that's the same question you should ask your physical or occupational therapist. So that's the first question. The second question is, I've been diagnosed with CRPS, and I've come to you for some opinions. And then you kind of look at the doctor and see, if they kind of roll their eyes and, shrug their shoulders and all. You're probably talking to somebody who doesn't believe that diagnosis. I think you really have the right, and I think you have the need to sort of assess the doctor's qualifications in treating what is considered by the American government a rare disease. Because if you're going to somebody who really doesn't understand this disease and kind of gives you the idea that they do, then you're going to wind up going the wrong way. And if you're not comfortable on that first visit, then don't come back. Because there are enough people out there who understand this disease that there's got to be one close enough by for you to go see.
iPain Foundation said, I would ask the doctor, what do you know of Dr. Schwartzman's and Dr. Getson's RSD research? Okay, so to follow up the last question, because they, from the Medicaid provide compensation, he said, is there compensation if someone is severely disabled by this?
Yeah, because, disability, Social Security disability, Medicare, again, if Medicare pays for it for any reason, they pay for it for this reason. If they don't pay for it because it's not part of their fee schedule, they will. So, I see people every day, and I bill Medicare, and I get paid the Medicare fee schedule that I bill for.
So as you said,
Medicaid.
Go ahead. Sorry.
Before somebody asks the question, state Medicaid is a whole different story because their compensation is based upon the doctor being a participant in the welfare program, and their rules are way different, and they vary state to state. Medicare, of course, is federal. Medicaid welfare system is state to state, so I can't answer as to that.
Okay. You mentioned earlier that CRPS or RSD has been around since the Civil War era. Why are so many doctors still unaware of what this is?
Anecdotally, by the way, there's actually a reference of CRPS allegedly in 17th century France, but yeah, mostly from the Civil War. I think it's because of lack of awareness. There's no course in medical school on CRPS. We're taught diabetes and hypertension and cholesterol and stroke and Parkinson's disease and et cetera, et cetera, et cetera. And I know when I went to medical school, reflex sympathetic dystrophy, as we called it back then, never came up. Mm-hmm. And unless someone who has knowledge of this goes into a school and teaches a course, people may never even hear it. So you come out of medical school never even having heard of it. So somebody walks in with the constellation of symptoms that we now know to be this disease. Well, they're looking and go, well, I have no idea what that is because they're where I was in 1980 something because I never heard of it. And there's no public awareness of this. I've said so many times for so many years, and I said it last night and will say it again tonight. I don't have Jerry Lewis, who made muscular dystrophy an everyday word. I don't have Michael J. Fox, who makes Parkinson's disease an everyday word. I don't have the constant barrage of people talking about Alzheimer's disease or 8 million commercials for statin drugs, what to do for your high cholesterol or for your migraine headache. There's nobody on TV talking about complex regional pain syndrome. So you'd be amazed at the number of referrals that I get from patients with this disease, from lawyers, from physical therapists. And so I'm educating doctors in my area one at a time. So when I go to a conference, and I'll be speaking at Pain Week in September, as I've done on a number of occasions, when I do those conferences, I'm talking to doctors and nurses. And so 200-300 people go home, and it's great because they, hopefully they're telling people and they're making diagnoses. But we need, and I've been saying this now for 20 years, I need somebody to stand up on Ellen DeGeneres' show and say, I'm disabled because I have complex regional pain syndrome, and since I know that you have no idea what that is, let me tell you about it, and get more than 3 or 4 minutes on a national television show so that people can go, oh my God, my next door neighbor, my cousin, my aunt, my son has this disease and it's been misdiagnosed all this time. Now I got to go find somebody who understands.
Oh, I was going to ask, why is there not a cure? And then I was also going to ask a question, what needs to happen in order for doctors to know what CRPS is, to have better treatments and medications, and for this to become an everyday household name like MS, Parkinson's, and Alzheimer's. And I completely agree with you. We have a few questions here. Does Dr. Getson believe that Dante's Inferno is a representation of a patient describing RSD?
I'm sorry, does Dr. Getson believe that what is?
Dante's Inferno is a representation of a patient describing RSD.
Well, I guess in the euphemistic sense, yeah. I mean, again, somebody has printed up a T-shirt that said, "If you want to know what it feels like to have RSD, pour a can of gasoline over top of yourself and light a match." So I guess that falls into the category of Dante's Inferno, because for me, the number one word that is associated with disease is burning. And I don't lead people. I don't say, does the pain feel like it's burning? I ask people to describe the pain, and when people ask what that means, I make burning one choice. It's hot. It's stabbing. It's pressure. It's sticking. It's heavy. It's achy. It's burning. It's cold. I mean, I just throw it in there and let people pick a word. Most times you don't even have to do that. Most times people walk in and say, my hand's on fire. But yeah, I mean, burning is the key word. When I hear the word burning pain, it's got to be nerve pain, and all of a sudden the hair on the back of my neck is standing up.
Last week we had guest Barbie Engel on, and she said that the McGill pain scale is obsolete now because I guess it was created in the 1970s. And also I had somebody mention, I'm tired of the smiley faces, sad faces, crying faces. What do you believe is the best way to, when you go into a doctor, to talk about the level of pain for RSD, and where does it run with everything else?
Well, I agree with her. The McGill pain scale is obsolete. I mean, you have a patient who comes in one day and they say, what's your pain on a scale of 1 to 10? They say 10. Okay, fine. And then you give them some kind of treatment, and they come back a week later and, okay, how do you feel today? Oh, I feel much better for the treatment. What's your pain? 10. Well, wait a minute. How is it better? Well, it really wasn't 10 the first time. It was really like 15, but I couldn't go any higher than 10. So, I mean, it's insane. So really what I ask people to do is I ask people to describe their pain, as I said a moment ago, and I ask them to quantify their pain relative to themselves. By that, which I mean, is your pain better or worse than it was before? Because that's an easy reference point. Now, sometimes I will say to people, on a scale of 1 to 10, but I'm really doing that not so much to put a number on it, but to get a sense for whether it's kind of low, medium, or high. Because people are with any kind of chronic pain are sort of in a quandary. How do I quantify my pain? I can't really. How do you put a number on pain? So I expand on it. Is the pain disabling? What does the pain keep you from doing? Does it wake you up at night? Can you ride on a roller coaster? I mean, it sounds like a silly question, but, because people understand those. And when you start to develop a sense for pain based upon the response, not to one question, is it a 1 or a 7, but rather you get a generalized explanation. And so if you make the proper notes on that, now you can go back and ask that question. All right, well, I didn't used to be able to walk through the mall, but now I can walk through the mall. Well, I don't have to ask them what their pain level is. It's got to be better because they're doing something they couldn't do before.
Dr. Getson, we are going to take a quick break and hear a word from our sponsor.
Hey, Sam. Say, I just heard about something that might really change your life. What do I mean? Well, you said your mom was having some medical issues, didn't you? And didn't one of your daughter's friends get approached by a stranger in the park last week? Yeah, I remember. Well, you've got to see this new technology. It's a wearable device, kind of like a Fitbit, but this one has wellness monitoring and a safety panic button, among other things. No, I'm not kidding. Look, you can only get this from a sponsor. Check out www.conspiraciesagainstwellness.com and look for David and Dana. They'll take good care of you. Got something to say? Get in on the conversation at 415-915-2291. That's 415-915-CALL-1.
Welcome back to Conspiracies Against Wellness with guest Dr. Phillip Getson. If you have a question for Dr. Getson, you could call in at 415-915-2291, or I will be reading your comments or questions off of YouTube Live. So we have a question, Dr. Getson, from Cameron B. Wiggins. Has stem cell research been effective in treatment, or has it been utilized as such?
Stem cell research for CRPS is really at the very earliest stages. There's not any significant data that I'm aware of to suggest that it works. Some of the anecdotal studies suggest that it's beneficial, and there's reason to believe that perhaps it will be, but at this point I can't tell you that that's an acceptable treatment because it hasn't been tested enough.
I actually had stem cell injections a year and a half ago in my neck because I broke it twice and I've had 5 neck surgeries, and it's helped that so much, but my doctor that did it is following me around to see if it helps for CRPS because they have a doctor there that understands CRPS as well. So it seems to have worked, but I've also made a lot of lifestyle changes too, which they weren't happy with. They wanted to have me as a test group and not do anything else, but it's my life. So Thayer Barnes wants to know, does Dr. Getson plan on teaching med students? I wish he would.
I actually lecture to medical students in the South Jersey area. I lectured interns and residents in 2 different hospitals. And up until a year ago, and hopefully it's going to reinstate, I was lecturing to medical students at the Osteopathic College where I went. I think someday what I'm going to try and do, and I'll probably solicit some help from someplace, is to do a webinar and let anybody who wants to join into the webinar, but it'll be a visual with slides and things. And we'll just get people from all over the country to log in, and they can be patients, they can be medical students, they can be physicians, and we'll just talk about the disease, and we'll do it a couple of times a year, and anybody who wants to learn, we can do it from the comforts of their own home.
We have another question. Is fibromyalgia and CRPS related and caused by neuroinflation?
Whoever asked the question, thank you very much, because I would have gotten, but you've given me a perfect opportunity. Please understand that what I'm about to tell you is my own position. I think that fibromyalgia is a subdivision of reflex sympathetic dystrophy. I don't really see them as 2 separate diseases. I think that when you, and I invite your listeners to go to the National Fibromyalgia website, because I've done this, and look at the definition of fibromyalgia on the National Fibromyalgia website, and then go to the RSD website and look at the definition of reflex sympathetic dystrophy, and you will see, okay, that they're virtually identical. I mean, it's scary how close they are. The buzzwords like burning and this and that and the next thing. So sometimes when I give a lecture, I will put the National Fibromyalgia website up there, and I will make that one of my earliest slides, and I will read it to the audience, and everybody goes, oh, yeah, well, he's in here talking about complex regional pain syndrome. And then at the bottom of the next slide, it says, well, okay, this is from the National Fibromyalgia website. I get doctors who argue with me and say, well, no, this one has this. I'm not saying they're identical diseases, but I think they're basically 2 branches of the same disease. Is it a neuroinflammatory condition? Absolutely. And the difference, of course, is that there's a ton of people walking around with a fibro diagnosis that probably have reflex sympathetic dystrophy, and probably 25%, yourself included, of people with complex regional pain syndrome will walk into the office and say, yeah, I was diagnosed as fibromyalgia a year, 5 or 10 years ago. Well, I don't know if you really ever had fibromyalgia at that point, or just the beginnings of what was then complex regional pain syndrome.
We have a caller. A caller from area code 505. What's your name and where are you from?
Hi, my name is Lori, and I'm from Albuquerque, New Mexico.
Hi, Lori. What's your question for Dr. Getson?
You know, I didn't really realize I was going to be on the air.
Oh.
But I guess if I am going to ask you a question, I'm going to ask you what are the most current and effective treatments to do if you know you're going to have surgery and you've already had complex regional pain syndrome. I'm going to have surgery.
Okay, this is a very easy question to answer. Dr. Schwartzman and I did a paper a couple of years ago, maybe 4 or 5 years ago, and we did a research study on the use of ketamine intraoperatively. And I did 22 patients, and he did about the same number. Now, in medical research, that's a very small number, 44 people. But of the 22 people that I studied in my practice that had surgery, and the surgery ranged everywhere from podiatric surgery all the way up to dental extractions, of the 22 people, not one person extended the reflex sympathetic dystrophy as a result of the surgery. Since we published that paper, I've probably seen 100 people who've had it, and I've only had one person who extended the reflex sympathetic dystrophy out of 125 people, which is an astronomically low number. So when somebody's going to have surgery, I get on the phone, I talk to the anesthesiologist, I write a prescription, I tell them that they need to have intraoperative ketamine no matter what the surgery is. And I also tell the anesthesiologist, because you can't tell doctors what to do, I always tell the anesthesiologist, if you want to give them other things, you give them whatever you want, as long as you put the ketamine in there. And the ketamine generally ranges anywhere from 80 to 125 milligrams of ketamine intraoperatively, along with whatever else they want to do, and it works wonderfully well.
So how do you currently treat your patients with CRPS?
First and foremost, mobilization. I tell people to move. Now, let's not confuse mobilization with exercise. Mobilization is move. You got a problem with your arm, make sure that you move your arm. As much as you can move your arm, whether it's the shoulder, the elbow, the wrist, the fingers, mobilize the joint, mobilize the limb. And I don't care whether they've had it for 1 day or 25 years. Keep moving, number one. Number two, get into a physical therapy or occupational therapy program with someone who understands this disease, because there's always something you can do. And with the new physical therapy modalities, with the mirror box therapies and the guided motor imagery, there's so much stuff that is being done that's just working unbelievably well for people with this disease. So you've got to have therapy that you can do, and you've got to do it. The third thing is diet and lifestyle alterations. Because, again, it doesn't matter if you have CRPS or any other condition, diet and lifestyle alterations. In this disease, which is an inflammatory disease, you've got to reduce inflammatory intake. You start by going gluten-free. It's amazing how much people get better just from changing their diet in short time. 5 to 10 days, people say, I stopped having gluten, and I really do notice a difference. Nightshade plants, eggplant especially, is a highly inflammatory food. You've got to get rid of those kind of foods. Number one, sugar. Number two, dairy. Number three. Now, there's people listening tonight, they're going, my God, that's everything I eat. You know, I eat sugar, I eat dairy, I eat gluten. Well, you have to make a decision. How much do you want to minimize your pain? Mm-hmm. Because if you really are serious about doing it, then you make the commitment to do these things. Number four is mindset. Not only yours, but in the people who accompany you, whether it's your mother, your father, your son, your daughter, your wife, your husband, whatever it is. The mindset is, and I said this to you before, the mindset is, number one, you don't talk about my RSD. Okay, don't own it, give it away. Because the message you're putting out there into the universe is that you own this disease. You don't own this disease. It's something you want to get rid of. Number two, you have to constantly be optimistic. If you have a bad day today, tomorrow's going to be a better day. And you have to do whatever is humanly possible to make yourself better, whether it's through diet, lifestyle, exercise, meditation, yoga. There's so many things that people can do, but you've got to buy into the fact that every minute of every hour of every day you are working to get better. And I'll tell you what, spirituality is amazing. And now, I'm not confusing spirituality with religion here. Spirituality of believing in a higher power than yourself and putting your trust in that power and having the spiritual need to say, you know what, as they said in the movie Network, where the guy threw the window open and went, I'm mad as hell and I'm not going to take it anymore. Every one of the people that's listening today needs to get up tomorrow morning, throw that window open and yell out the window, I'm mad as hell and I'm not going to take it anymore, and find a way to start getting on that road to better. Because no matter who the doctor is, no matter what the best therapy is, no matter what the best treatment is, okay, I can write a prescription, I can write a diet plan, I can write a lifestyle plan, I can write an exercise plan. Ultimately, you're the one that's going to do it. And one of my favorite analogies comes from The Wizard of Oz. I tell people that the Munchkins put Dorothy on the yellow brick road. She walked. So if whoever put you on that road, you're the one doing the walk. And you've got to do it day in and day out. It's a lifetime commitment. And if you do the things you have to do, you will be better. You will make yourself better. And the amount of better varies from person to person, but better is still better. So my treatment starts with all of those things for everybody. And then it depends upon what treatment an individual has had. It depends on how long they've had the disease. You know, I see people that come in that have had the disease 5 and 10 years. I don't often see people that have had it 5 or 10 weeks. And so maybe they've had a whole series of injections. Did they work? Maybe it's good to revisit them. Maybe they've had the epidural catheter infusions. Maybe they've had hospital-based infusions. You know, I'm a firm believer in ketamine for refractory disease, and I'm sure we'll get back to that. There are people with spinal cord stimulators, not one of my favorite things for lots of reasons. So you have to kind of pick and choose, but it really is, after you get through those first 5 things, which everybody gets, now it depends on the individual.
I've been dealing with diseases and chronic illness since I was 16, so it's been 23 years. And then I started having symptoms of CRPS, RSD in 2009, and then I wasn't diagnosed till 2015. But once I found out and I started reading about it, I just did exactly what you said. Because it's in my power. You know, I wanted to be able to do everything I could do to help, along with medications or treatments. But I changed my diet to anti-inflammatories and antioxidants, and cut out nightshades and gluten and dairy and red meats. And then I started using laws of attraction. I made a dream board or a vision board. I started meditating, doing breathing exercises and stretching to keep my back aligned and, you know, to get my core strong. And then exercising. I created an exercise program that I do 3 times a week. And if I can't do it, if I'm hurting too bad, I do something else. But you're absolutely right. It's changed. It's been 1.5 years since I started this. I've gone into remission 2 times in the past year for CRPS RSD, and I've never experienced this level of health in my adult years. So I completely agree with you, and we have a lot of comments. Actually, people are saying the exact same thing. Like, you know, they completely agree. I wanted to ask you a question. I don't know if you know what ketones are. Well, you probably do, but last week I started taking ketones, and my fiance and best friend started taking them as well. My best friend has PTSD, and he is doing really well. He started it actually 2 weeks ago. And my fiance has diabetes too, high blood pressure and high cholesterol, and he's been doing well. They have no side effects. I spoke with my doctor prior to trying them, and she said she didn't see any harm in taking them. I was on them for 4 days. I felt nauseous after I took it each day. I was taking like a half a pack. Then they told me to take a quarter of a pack. I've gone into a full-blown flare in the last week. My hands have been swollen every day. I broke out in hives on my face because I have CRPS in my hands, both arms, hands, face, head, and mouth. Yesterday I was supposed to take, 2 days ago I was supposed to start taking it twice a day, and I mentioned to a friend. She's a doctorate. She said to stop immediately. She said anyone with an autoimmune disease or any other certain diseases like what I have basically should not be taking ketones because it will mess up my adrenals. What do you think about this?
Well, you sort of took the words out of my mouth. first of all, you don't want to take it with an autoimmune disease. Secondly, it will mess with your adrenals. And third, remember this, one of the things that goes along with complex regional pain syndrome is an impaired immune system. Your immune system is working 24 hours a day to try and fight off this invader that is complex regional pain syndrome. It doesn't need any more abuse. And so you're putting your body into a ketotic state for a centralized disease. Now, the other two people you mentioned, PTSD is more of an emotional related issue. Hyperlipidemia is cholesterol, triglycerides or both, but it's not an autoimmune disease, and it's not something that impairs the immune system. So someone who might get better with those two diseases is not someone whose immune system is getting thrown into disarray. I mean, your immune system has, what did you do? Mm-hmm. I mean, what are you thinking? Well, and your adrenals are probably going, I'm just not capable of doing that. It's like giving a little old lady 200 pounds and asking her to carry it up a hill. Mm-hmm. Because your adrenals are working hard enough. You don't want to give it any more work to do. So I would certainly not recommend. I've never, by the way, recommended ketones to anyone for this disease, nor would I.
Mm-hmm. So, well, the people that it's two doctors and a few other people. They told me, just to keep doing it, and my body just has to get into ketosis. So I should stay away from this. What health conditions would ketones be good for? You mentioned PTSD is, not bad.
Well, I you got to be careful when anybody that has liver problems, kidney problems, heart problems. Yeah, I mean, it's not something that I do, and not something that I'm going to sit here and express expertise upon. But I just think that, from what you said to me and to the group in the last few minutes about eating properly and all, if you're eating properly, then you don't want to throw your body into a ketotic state. You want your body to auto-balance. Human body is a marvelous thing. It will balance itself correctly. And now what you're doing is you're taking the natural balance of nature with ketones and throwing it out of balance. And you're saying, okay, now that I've thrown it out of balance, now I'm going to make the body work harder to get it in balance. And that just doesn't make sense to me. So it's not something I would recommend, quite frankly, to anybody.
So the keto...
And by the way, the comment you made where your body's just got to get used to it, how long do you have to live for somebody that has autoimmune disease, a malfunctioning immune system, and adrenals that are overtaxed? I mean, that comment makes no sense.
Okay, yeah, because I was on my way back into remission, and then I heard about this, and I know a few people are taking the ketogenic diet too. So that's high fats, high proteins, and low carbs. Is that an okay diet to do, or with somebody with CRPS, or should they not be doing it?
No, I think if they're good fats,
yes,
fine.
Good fats. Okay.
Yeah, but I mean, good fats are great. Good protein is great, and low carb is good. So that kind of diet is very healthy.
Okay. So I have CRPS in both arms, hands, mouth, face, and head, and I've always taken great care of my teeth. CRPS moved to my mouth in around 2013, and since then, my teeth have become brittle and break. I've had to get 21 root canals in the last 4 years. Why is this happening? I know there's a lot of people that have mouth issues once it moves there.
Well, there's a couple of theories. One theory is that a lot of people mouth breathe because of the pain, so they get dry mouth, which is going to adversely affect the teeth. Second theory is that the medication that people take for the pain and for the disease is rotting out teeth. The most common theory is that because this is a disease of the nervous system, and you seem to be living testimony to that, it's affecting the nerve roots, and if it affects the nerve roots, what's going to happen to the teeth? The teeth are going to be sick, if you will, and it doesn't matter how much good care you're giving to them externally, because internally the supply of nutrients through the nerve root is impaired. So, oral hygiene is important, but it's really important to drink a lot of water, keep the mouth moist, and when you can, to minimize medication. And if you can get some control of the disease, then you're going to control not only the disease in terms of, okay, my arm hurts, but also the disease in terms of the nerve roots that supply my teeth are functioning in a better fashion.
I've been told not to get root canals because each tooth directly affects an internal organ, and I was told instead to have all my teeth pulled and get dentures. I wanted to keep my teeth. Anytime I go to the dentist, even for a cleaning, I take an antibiotic. What is the best way to deal with mouth and teeth issues that occur from CRPS?
Wow. with the understanding that I'm about the farthest thing in the world from a dentist, it's not an unusual question. Antibiotics prevent infection, and there's something to be said for that. I tell people, if it's exactly what you just said, I tell people not to get root canals. But I tell people not to get root canals whether they have CRPS or not. I mean, if someone walks in and they're reasonably healthy, I still tell them to take the tooth out as opposed to having a root canal. I mean, my general practice, I tell people not to have root canals. Now, understand something. When you're dealing with a nerve root that's alive, for the reasons that we talked about in the preceding couple of moments, you're just opening yourself up to somebody going in and drilling on a nerve root that's already malfunctioning because of the centralized disease, and it's not going to be happy. Mm-hmm. So I understand on one hand wanting to keep the teeth, but when you have all those root canals, number one, you're setting off the CRPS, and number two, you're right. I mean, every tooth by meridian is connected to an organ. So what is the impact of pulling out the tooth X, Y, Z? It doesn't make any difference. How does that affect? And I'll tell you a really interesting statistic. I wish I had the citation, and for some reason it has slipped away from us. There was a paper that said that 85% of women with diagnosed breast cancer at one point in their life had a root canal on the same side of their mouth as the breast cancer.
Mm-hmm. Wow.
Now, that's a staggering number, 85%. So, if people are not going to pull the tooth, then you've got to just, if you can get the oral surgeon to give you some office-based ketamine, because a lot of them will go up to 80 milligrams, that will help the nerve part of it. Doesn't help the organ part of it, but it helps the nerve part of it. So I surround myself with people like oral surgeons that I know who, if I send somebody over because they just decide, okay, I'm going to have this root canal or I'm going to have this extraction, in the office they'll give them ketamine to minimize the likelihood of problems or spread. And other than that, minimize the medicine, maximize the water, and keep doing what you're doing, and hope that you're not one of those people that it impacts negatively, and no matter what you do, it just goes bad.
Mm-hmm. Yeah. Well, I did have one tooth pulled in 2013, and, I don't know. I was always told, you're supposed to keep your teeth. That's from my dad, obviously. But, I just didn't, I would have 22 teeth out right now, and I didn't know how to deal with it. I appreciate you talking about it. You mentioned earlier about medication and stuff like that, and I just wanted to let you know, like, I've I weaned myself off all my meds in November, and that's when I started all this diet and everything like that, and I got a ketamine infusion, and I went into remission until March, and then I had to get root canals, which pulled me out of that. Anyway, I started taking medicine again, and I was on morphine, Soma, and something else. I'm off all of that now. And I haven't had my period in 3 years, and I started getting my period. I was off of it in March. I got my period April, May, and June, and now July. Is this a normal thing? Like, I thought I went into menopause, and I thought I could never have children.
Well, if you're asking me whether there is a relationship between the medicine and the lack of menstrual periods, the answer is probably not. Mm-hmm. If you're asking me whether or not that one of the things that happens to women with CRPS is they have menstrual irregularities, either no menstrual periods or multiple menstrual periods or different menstrual periods, the answer is absolutely yes.
Okay. Yeah, because I went off my birth control 3 years ago, and I never got it again. And then the only thing, lately, in the last few months that I changed was going off of morphine completely, and it came back. So I'm not really sure why it did. I mean, it's 3 years of nothing. It was just strange.
You went off of morphine because you were better.
Yes. Well, yeah, and I didn't want to be on it anymore.
Better, the RSD receded to some degree. Mm-hmm. I won't call it remission, but it was going in that direction. And so as the RSD became less of an issue in your life, your body got into a more normal state, which is probably why you start having menstrual periods again.
Okay. So you talked a little bit about ketamine, and I read somewhere that, you are pretty much the pioneer in the United States with ketamine. Can you talk a little bit about it? And I've had it 5 times. It was different each time, but I know a lot of people are interested in that.
Yeah, ketamine's been around since 1963. It was originally brought to the American people as an anesthetic for operating rooms. So if your family member had a gallbladder surgery in 1964, they probably got ketamine to go to sleep. It's a very safe drug. It has a very short half-life, so it's in and out of the system in very short order. And today they're actually still using ketamine to some degree in dentist office, as I just explained. Use it in emergency rooms because if you have a child who was burned and you have to change the burn bandage, kids are not real good about sitting there and letting you change a burn bandage. So they go to emergency rooms, will give the kid a shot of ketamine, kind of knocks them out for 5 or 10 minutes. The child wakes up and goes home, doesn't remember the change of the bandage, and doesn't have the pain from it. And when you give things to kids, you're usually pretty safe. I mean, so it's a really safe drug. The reason it's not more used in emergency rooms is because the natural evolution of pharmacology is we'll find something better, we'll find something better, we'll find something better. But ketamine's really not a bad drug. In 1990, probably 7, a doctor from this country by the name of Ron Harbit and another doctor whose name escapes me at the moment, who was an Australian clinician, were working in the country of Australia on chronic pain patients and actually stumbled on using ketamine for the purpose of treating the chronic pain of CRPS, and they found that it worked very well. So they began using ketamine in varying doses intravenously in a hospital-based setting, and it really worked well enough for them to write a paper. Graham Carell was the other doctor, by the way, in 1999. That got published, and that's really the first paper of its kind that talked about ketamine used for complex regional pain syndrome. Dr. Harbit moved back to this country. He was in Pace, Arizona for a while, where he was giving hospital-based intravenous ketamine, and recognizing that he thought it could help a lot of people, had the fortitude and the foresight to come east and met with Dr. Schwartzman in Philadelphia and said, I got this thing and it really works and I'd like you to look into it. And Dr. Schwartzman realized that it was going to be a great help and was kind enough to invite me to be a part of the original protocols. And so what we did was we started using ketamine both as an outpatient and an inpatient in varying doses. And we found out that ketamine worked really well in a very controlled setting with a lot of adjunctive things, because if you give somebody too much ketamine, in addition to making them very tired, you run the risk of hallucinations, which are all dose-related. If you give somebody ketamine and they see little green men and you back off the dose of ketamine, it goes away within minutes. So we came up with a protocol that was published and was used, and now I will tell you that when we started, which was roughly 2007 or 8, there were 3 of us in America doing ketamine, Dr. Schwartzman and myself and Dr. Arbit, and now there's probably 60 or 70 or 80 or 100 people around the country using ketamine. And unfortunately, one of the things that's happened with that is that everybody thinks they can do it better, so they have varying degrees of the way that they do it in terms of how many treatments, how often the treatments are, how much they give, and success varies with different ways. That prompted a group of us to meet last October in Chicago to try and standardize the protocols for ketamine once again. And the results of that conference are currently being written so that we can publish it and make it available to the medical community. It's really not out there yet. The one thing that I've learned for those who are listening is that it is always better to give low doses of ketamine over time as opposed to high doses of ketamine over a short time. You get less side effects and better result. Now, I also want to make it clear that I don't think ketamine is a cure, nor do I think ketamine is for everybody, nor do I think ketamine should be the first line of treatment, because there are other things that may work. But ketamine works beautifully in refractory CRPS, meaning this gentleman or this lady had blocks, she had medication, she had physical therapy, and she's just not getting better or maybe getting worse. Well, at that point in time, ketamine becomes a viable option. It works really well. We do it in the office. It's a very controlled setting. People are monitored like if they were in intensive care. There's a nurse in the room with them. They're hooked up to pulse oximetry and blood pressure and heart monitoring and blood pressure and everything, and people really, really do well. They get better in the sense that they have less pain, they have more functional capability, they take less medication, and I put some people into full remission who don't come anymore. It's a very exciting product when used properly. I've also seen it used improperly around the country, and people get worse, and then they get on the millions of chat rooms and go, oh, this doctor gave me ketamine, and all I did was go into a flare and I got sick. So if you're going to get ketamine, you got to do your homework and research it and make sure who's doing it and what that person's track record is.
Yeah, absolutely. Like, I have like a system I do before I prep before I do it. I go off all my pain meds because I heard that it attaches to the same pain receptors, so you can't have that on there. Which, please let me know if that's wrong. And then I drink coconut water for 3 days beforehand. I just make sure I kind of clean my whole system out. Do you agree with that, or should people have a regimen before you?
Yeah, it's ideal to get off the medicine, but not everybody can. There's some people that are on so much medication, so we try and taper it down. We try and get them on the least possible dose to get the best possible effect. And anybody who does what you do, and by the way, it is a rare breed of people who will cleanse their body and purify it and drink the coconut water and do all those things. But anything you can do to make yourself better, to use your words from earlier, within your control, anything you can control helps me help you.
Absolutely. We have a question from Thea Barnes, which she's from Canada, so I'm not sure if ketamine's different there, but she asks, why are so many people against ketamine if it's safe?
By the way, everything's different in Canada. Thermography is different in Canada, too. I think there's a lot of answers here. I think sometimes not knowing creates a bias, because they're looking at it and they're looking and saying, well, kids abuse that drug on the street, that's special. Okay, well, yeah, that's true. But it's real. I mean, when you look at the medical literature and not at the abuse potential, I mean, people who are old enough to remember Quaalude as a sleeping pill might be the best sleeping pill that ever existed, but they abused it to the ends of the earth and ultimately caused the government to pull it off the market. So you can't judge a drug by how it's being abused by a small percentage of the population. And I think a lot of people don't know what it is. And remember now, the pharmaceutical industry has tremendous clout. If I have somebody on ketamine and they don't need to take prescription medicine anymore, the pharmaceutical industry is losing money. So a lot of the bad-mouthing that comes along comes from people who either A, don't know about it, B, really don't want you to get better, and believe me, there's lots of them in this world, or C, who are getting ketamine in a wrong way. I mean, there are doctors giving people 1,000 milligrams of ketamine in one sitting and expecting them to walk out and go home, and that's just insane. I mean, we don't go above 250 milligrams. There's doctors giving people 4 times that much. So, if somebody gets 1,000 milligrams of ketamine in an outpatient setting, I understand why they're bad-mouthing it. But when done right under properly controlled settings, I will tell you that in all the years I'm doing this, and I've probably done 300-400 people, I've never had a side effect.
Yeah, I get
it. Again, we have people with side effects that are dose-related because sometimes you overshoot. But when I say a side effect, I mean one that wasn't reversible within a matter of an hour.
Wow. Yeah, I get it about 100 to 110 milligrams. What do you think about the 5-day ketamine thing where they put you in a coma, I heard, and give it to you for 5 days?
Oh, so there's a couple of answers to that. Number one, it's illegal in this country.
What? Really? Because I know they do it in North Carolina.
If they're doing it in North Carolina, please send me an email and let me know where.
Okay, I will,
because we've tried to find that. We're being told by the FDA that it's illegal in this country. Now, if they're doing it in a VA hospital, sometimes the VA people get a little special dispensation from the FDA. It's an incredible procedure. When ketamine started, we used to send people to Germany and do it. And the people that went to Germany, I mean, the results were just mind-boggling. I had a young girl come into my office. She was about 20 years old, and she looked like a Raggedy Ann doll. I mean, literally, she couldn't sit up. She was restrained in a wheelchair. Forget about standing up. She went to Germany, had 5 days. I saw her 2 months after she came back, and she literally ran into my office and jumped up on the table. I mean, the results were astronomical, with the asterisk that you need the boosters to follow up with it, because you can't just get the 5-day coma and expect it to work forever. But it's also scary.
Yeah.
I mean, when you tell people to put them in a drug-induced coma for 5 days, especially if they're going to a foreign country to do it, there's a lot of scariness that goes there. Most of the people who have undergone it are people who have come out the other side and been much better as a result. Because the more you can give it under controlled conditions, which is why hospital-based infusions, you can give a little higher dose than you give in outpatient infusions, and they work better and faster. Again, I keep using the word control. You've got to know what you're doing. You've got to really be on top of it. And if you are, then it's great. But you got to make sure you know where you're going and what you're doing.
Well, I was supposed to get it last May, and I decided I wanted to try everything else before I did that. With like the boosters and stuff like that. But I'll definitely send you the name of the doctor and stuff and where it goes. It's not a VA hospital, I'll tell you that. We have a question. I was told ketamine was used as a horse tranquilizer. Is that true?
Yep.
Okay. Another question. When doing exercise, is it a good thing to push past the pain or to go just where you could stand it?
Okay, so let's talk about pain for a minute. Here's an example that I use. Two men are out shoveling snow after the first snowfall. They're neighbors. They've been friends. They're same age and same basic body build, and they're basically both healthy. The first guy's shoveling snow, and his back's beginning to get a little achy. His legs are beginning to get a little achy, and he knows he's going to get up tomorrow morning, and he's going to know that he was shoveling snow that he hasn't done in a year because he's going to hurt. He also knows that 2 or 3 days later he's going to feel better. The other guy's shoveling snow right next to him, and halfway through the snow he feels something pop in his back. That guy needs to put his shovel down and walk away. Mm-hmm. So when it comes to pain, your body is talking to you. When the muscles start to burn, and it's hard, that's a hard thing because you're burning going in, so how do you determine burning on top of burning? Mm-hmm. Most people know when you got to that point. When you get to the point where your mind says to you, you know what, it's time to stop, it's time to stop. I do not like people pushing through it because pushing through it, hurting is one thing because you can recuperate it from it. Hurting past the point means you may have done some damage by trying to do something you shouldn't do, and that damage is irreversible. So I tell people, get to the point where you know your mind and your heart are telling you it's time to stop and walk away.
Right. Yeah. I always say there's a good hurt and a bad hurt. The good hurt is sore muscles, maybe tiredness. The bad hurt is the sharp pain, and when I feel that, I stop. I used to not do it, though. It took me a long time to learn what I could do, and I wasn't good at saying no. So we have another question. It goes back to the ketamine. Is the FDA the problem with this, not allowing the 5-day medically induced coma?
FDA is absolutely the problem with that, yes.
Okay. So I want to know, what is CRPS actually? Like, what is going on inside the body when someone has CRPS?
If I could answer that question, I'd be not only famous but probably rich. Because I don't really think anybody knows the answer to that question. The current thought process is that the glial cells in the brain are malfunctioning, and there's a lot of research being done that has not been proven definitively, but that's the research theory. There are people who tell you that it's not a malfunction of the sympathetic nervous system. I really don't believe that. I really believe that the sympathetic nervous system is malfunctioning, but I can't tell you why. And if anybody tells you that they absolutely know why, then please give them my name and phone number because I'd like to hear it.
Okay. We're going to take a quick call. Caller from area code 801. What's your name and where are you from?
Lynn Wilburn from Salt Lake City, Utah.
Hi, Lynn. What's your question for Dr. Getson?
I had heard that Dr. Getson is studying people who have these conditions in their family. I have fibro, CRPS. My daughter has fibro. My granddaughter has fibro, CRPS, celiacs, and POTS. And my son has musculoskeletal pain. And I'm pretty sure there's a very direct reason we've all got it. I'm just trying to figure out if there's anything we can do or ways to present it on the way down the line.
Well, there's two parts to what you said. We started to do a research study on people to determine if there was a true genetic predisposition. Now, I can tell you that there is no question in my mind that there's a genetics involved in this. I've got way too many families, and there's as many as I see in my own practice. There's 3 times that many people who have, through the internet or other ways, contacted me as you're doing this evening. And so we started to do a study because there was a company that was doing it as a research project and not charging anybody any money. And we collected a whole bunch of data, and the doctor in charge of the project left the company, and the company said, well, it was his baby, it's not ours, and it fell apart. Much to my great dismay. We never came up with any conclusions based upon the data that we had. So at this juncture, I am trying to find someone who will allow us to do a research study, because the estimate that I got to do this the proper way run anywhere from $500,000 to $1 million. And that's not the kind of money that people just willingly fund. So we're looking to try and find the genetic to it that will allow us to help people such as yourself and your family. The only thing that I can tell you in a family such as yours is that if you know there's a genetic predisposition, then if someone gets injured, someone who may not have any symptoms at this juncture, someone gets injury, however that innocuous that injury might be, you want to start thinking that that person is going to wind up having CRPS sooner rather than later, and find somebody to intervene and start treating as soon as possible with the things I talked about. You know, let's start getting into physical therapy, even if they don't think they need it. Let's start making sure we get the diet and lifestyle alterations. Let's make sure we're doing all the things right. And then if the disease begins to localize into a place, well, then get to somebody who can treat that area before it becomes a full-blown forest fire. It's easier to put out a fire in one tree than in a whole forest.
We have another question from YouTube with ketamine. Can you explain the different versions of inpatient versus outpatient, not coma though?
Yeah, the difference is actually in dosage. In an outpatient dosage, at least in my practice, we rarely go above 250 milligrams over 4 hours. Now, that's a total, not 250 per hour, 250 total. So people are getting roughly 62.5 milligrams an hour for 4 hours. In the hospital, we take people up to 40 milligrams an hour, but we do it 24 hours. So you're talking about somebody on one hand who gets 250 milligrams and somebody on the other hand who's getting 1,000, but it's spread out over a 24-hour time frame. And it's different when you're in the hospital because they're hooked up to cardiac monitoring, but they're actually getting less per hour over more days. And it really does work better. The big problem with that is to get, who's going to pay for that? Because insurance companies, as a general rule, some will pay for outpatient ketamine, almost none will pay for inpatient ketamine. But when we can get it approved, or when someone has the financial wherewithal to do it on an inpatient basis, it's a great way to start, because you can load people up in a very safe, efficient fashion and start getting them better much faster.
Somebody else asked, how does Dr. Getson feel about high-dose vitamin C?
Dr. Getson doesn't feel one way or the other. I think that if you take high-dose vitamin C, I think it's great. It goes to keeping you healthy. I don't have any reason to believe that it makes you any better or not from CRPS. Anybody comes in and wants vitamin C infusions or high-dose vitamin C, I'm happy to do it for general health purposes, but I'm not going to tell anybody that it's a bona fide treatment for the disorder. If it makes them better, great. It certainly helps the immune system, which goes back to an hour ago when we were talking about eating right and doing all the right things. So I'm certainly not going to discourage it. I'm just not going to advertise it as a treatment specifically for the disease.
We have another call. Caller from area code 832. What's your name and where are you from? Hello, caller from 832. Where are you from? What's your name? Okay.
Janelle.
Hi, yes.
Hello.
Hi. Hi.
It's Sherry.
Hi, Sherry.
I'm
How are
sorry.
You? That's okay. What's your question?
I'm good.
Good.
Well, I wanted to know about spinal cord stimulators. I heard the doctor say that he's not so much for them, and I'm kind of the same opinion. So I wanted to know briefly what his opinion is.
I was going to ask that question.
Okay, easy question for me to answer. Mm-hmm. First of all, there's two basic spinal cord stimulators. There's the ones that have been out forever and a day, and then there's something that's been out for about a year. that has been advertised as being specific for CRPS. Here's my problem with spinal cord stimulators. There's actually several, but let me take them backwards. For someone to be considered a spinal cord stimulator candidate in my office, they have to have one limb disease. And what that means, if somebody says to me, if you fix my arm, I'm perfect. I'm exactly the way I was before I got this disease. I don't have any problems anywhere in my body except my right arm. That person gets considered, because once you start getting right arm, right leg, constitutional symptoms, gastroparesis, lack of menstrual periods, urinary problems, whatever it happens to be, that stimulator is not going to control those constitutional problems. So I very rarely recommend spinal cord stimulators because I very rarely see people with one limb disease. So that's my main problem. Here's my second problem. Most of them are done in two parts. The first part is a trial. We're going to put these in percutaneously. Meaning we're going to take you to a room. We're going to make you kind of sleepy, but we're not going to knock you out. And we're going to put a needle in your back, and we're going to put a wire through the needle, and we're going to hook it up to a box, and you tell me whether or not that makes you feel better. Well, okay, here's the problem. You're half sedated, and what does better mean? So they're doing what I consider to be, even though using fluoroscopy, it's still a semi-blind procedure because they don't really know if it's where it belongs. So let's say, hypothetically, you say, yeah, I feel better. Now you go home and you take your box home and you turn it on and off, and 5 days later you think this is the second coming of chocolate, and they take the wires out, and now a finite period of time later, they take you back to the room, and now they make some incisions. They make one in the back, and they permanently implant the wires, and they make one in your buttocks, and they permanently implant this little box, and they put the two of them together, and they either sedate you, or they do it the same way, which is semi-sedate you and say, well, I want to make sure the wire's in the right place before I hook it up. We have the same problem because if you're a little bit off, if you're a few millimeters off one way or the other, if you're not exactly the same place that you were the first time, there's no guarantee it's going to work the same way as it worked the first time. So I've seen a bunch of people come in where it works really well as a trial, but then when they put the permanent in, it doesn't really work the same way because they're not sure that it's where it goes or how it's supposed to go. I have advocated for the last 20 years to have spinal cord stimulators put in with a thermographic machine in there, because then you can put people to sleep and you don't have to ask if it's in the right place because the thermal imaging camera will tell you that. And try as I might, for 20 years with all the spinal cord stimulator companies, nobody seems to believe that I have an idea. And the beauty about thermography is that it will change from cool to warm, and the camera will show you that. So if the camera shows you that, I don't need to semi-sedate you. I can knock you out because I know it's in the right place because I've got a picture in front of me that's telling me what I need to know. So I have a lot of problems with stimulators, which doesn't make the stimulator companies happy, but I probably have 3 or 4 patients in my whole practice that have them, and I probably have 10 in my practice who somebody put a stimulator in at one time that they can't wait to take out because they don't turn it on and it doesn't work right.
Yeah. Different doctors throughout the years, whenever I've moved, they've wanted me to get one since 2005, and I'm afraid. Like, I did research on it back then, and obviously I'm sure there's some better ones now, but I just heard the leads burn out, your battery doesn't work right. I was afraid, and I didn't have CRPS then, but even now I was asked again, and I hear so many people that are asked, and I do have it in more than one limb. I'm worried about it moving. Like, is that a real thing?
Rarely.
Rarely. Okay. I didn't know that. Okay.
But you have your face, and I don't know how they propose to help you with your face with a stimulator. So just a thought.
Yeah. Somebody asked, how can high-dose vitamin B and C be bad for you? Or can it be bad for you? I'm sorry.
High-dose vitamin C is probably not going to be bad for you. High-dose vitamin B, did you ask me that question? Did I hear you right?
Yeah. Somebody asked, can high-dose vitamin B and C be bad for you? Both of them.
Well, it depends on what B. There's only one C, but there's multiple B vitamins.
Right.
You can actually give somebody, if you give somebody B6, which is pyridoxine, you can actually make their pain worse if you overload them. So that's not a real question because B has to have a number after it. B1, B2, B, high-dose vitamin B12 is not going to hurt you because that's excreted in the urine, what you don't need. But some of the other vitamins have the potential, if overloaded with them, to create more problems than the benefits that they give you.
What causes CRPS to move to different parts of the bodies?
As I told you earlier, if I knew what caused CRPS, I'd be smart and rich. The same answer here is there's one article in the medical literature, by the way. It was written in a journal called Pain, P-A-I-N, in 2001. If anybody wants to look it up, Dr. Schwartzman wrote it. It's really the only article that talks about the migration, but it really more quantifies the migration as to how long it takes and where it moves. Nobody knows why it moves, but I can tell you that in almost every patient that I see, it moves.
Okay. When CRPS moves full body and to the internal organs, what is life like for a patient at that point?
Largely depends upon the patient's response to treatment and the patient's response to, I'm mad as hell and I'm not going to take it anymore. I mean, I have lots of people that have multi-limb disease or constitutional internal symptoms, and their quality of life is pretty darn good.
Okay. If a patient has CRPS, what can be considered remission?
I honestly don't know how to answer that question. I think remission is graded as to people being able to improve their quality of life. Okay. I don't know that there's a medical answer to that. I think going toward remission is, hey, I'm taking half. I had a woman in today who has gotten off of all of her medication, and she still hurts, and she's still not working, but she's thrilled to death because she's not taking any drugs at all. Mm-hmm. Well, I mean, that's, I guess, a form of remission. I have other people who take medicine, but they go to work. So there's no clear-cut answer to that question.
Mm-hmm. Is everyone with CRPS-RSD able to go into achieve remission?
Oh, I think so.
And how can someone go into it?
If you believe there's not that potential, then why bother?
Right. How does someone go into remission? What do you have to do to go into remission?
You have to believe first. Mm-hmm. And then you have to do all those things that you described as things you can do for yourself. And then you have to have some help. And the help comes from qualified medical personnel.
Okay. What do you think about the opioid crisis and the CDC wanting to take people off opioids or lower them?
Well, if you have an hour,
yeah, I know.
we can go through that. I think there's so much to be said that there's no straight and simple answer. I think one of the problems is that we have not been given by the pharmaceutical companies any real viable medicine that doesn't classify as an opioid to control pain. So what are you supposed to give somebody if you can't give them something to control the pain other than an opioid? And I think that's a huge problem that isn't being addressed. I think the second problem is that while I understand what the government is trying to do, they're not talking to doctors and they're not looking at people on an individual basis. And I think that it is incumbent upon the doctor treating the individual to say to the parties that be, I believe that this person needs that medication, that it's in their best medical interest, and without this they will have no quality of life, and that they will fail to be anything other than bedbound, because you have to be an advocate for your patients. Clearly, you have to get people on the lowest common denominator of medication. But you also have to take every person as an individual and decide what somebody needs and work toward getting them down, work toward getting them off the medicine, work toward getting them better. And while you're doing that, you have to fight for them to make sure they get what they need.
I know you answered this earlier, but Michelle Hess asked, with CRPS being around so long, why do doctors still not know about it, at least?
I think it's lack of publicity. Mm-hmm. I think that the day that we put a mega star on TV and they come out and say this is what they have, I think that changes. I think it then it necessitates more education of the disease, and until we get that, we're just going to have exactly what we have, which is there are going to be those who know and those who don't know. And those who don't know but want to learn, and little by little, we're just educating people one at a time.
Somebody wanted to know, what do you think about the neurodronate infusions. I probably said that wrong. That they're doing in Italy, and I think they're doing some trials here in the United States.
Yeah, neridronate is a second-generation drug. Pamidronate was the first one. That was actually released for bone cancer right after the turn of the 21st century. I have two answers. The original study of 21 women that was done in Italy that brought neridronate to this country for this study that you're talking about was probably a little bit skewed. It was done in a very small group of people with very isolated diseases. I talked to a gentleman last week in New Jersey who's part of the neridronate study, and he's encouraged by it. I don't really know if it's going to work or not work. They spent a fortune getting people involved in doing this study. Some people think it's just a panacea and it's going to fix everybody. Other people look at it with a jaundiced eye. And for me, I hope it works, but I don't think anybody knows at this point if it's going to.
Is there anything else you would like to add and tell our listeners before we get going?
Yeah, I think to summarize, there's a couple of things I'd like to say. Number one, mobilize. Don't own the disease. Have the right mindset. Learn as much as you can learn from reputable sources, because some of the chat rooms and websites, and you got to look at where it's coming from, because some of those chat rooms just give people an opportunity to get online and complain. And you want to surround yourself with positive thinking people. If that chat room is mostly, oh, I can't do this, and oh, my doctor this, and oh, my wife this, then just get out. Surround yourself with as much positivity as you can. Educate yourself from reputable sources. There's plenty of lectures online. I've done some YouTube videos that are intended for the masses, not intended for doctors. And you learn things from talking to people who understand. There's lots of us out there who've done videos, and 5 minutes into listening to the lecture whether the person understands what they're talking about. If you're going to get therapy, make sure you investigate the therapist. If you're going to go to a doctor, make sure you investigate the doctor. Make sure you eat right. Drink plenty of water. Get some exercise. Get out in the sunlight. I mean, simple things that our grandparents took for granted that we don't do anymore. And learn about as much as you can about the human body with other diseases, because everything is interrelated. As I said at the very beginning when we were talking about TDI, if people go to the website, which is T as in Tom, D as in dog, I as in ice, NJ for New Jersey, TDINJ.com, they will find a link that says webinar link. And the webinar links are all on YouTube, and they're all free. And as I mentioned earlier, my wife put these together. She's just done an incredible job of doing this, bringing quality people on to talk about varying subjects, and a tremendous learning experience to learn about. Maybe it's not about CRPS. Maybe it's about ADD, or maybe it's about chiropractic, or we have one on smoky cessation. Things that you learn, because the more knowledge you have from really good sources, the more likely you are to be able to overcome the small roadblocks that get in front of you. And just don't give up, because there's always somebody with another answer. Yogi Berra said it best, it ain't over till it's over. And there's always something new coming out, and if the doctor across the street doesn't know, well, maybe the guy across town does.
Right. Just so you know, Ka posted your YouTube lectures on all of our social media outlets, and I just wanted to let you know there was a ton of thank yous, and they learned so much off of the comments and the questions link from YouTube. Well, Dr. Getson, thank you so much for being a guest on Ka, and we are honored to have you.
Well, it's really been my pleasure, and I'm glad to be able to answer the questions. The questions were terrific. They're coming from people that are asking questions that not only help themselves about the question they're answering, but they're questions that apply to so many people that are listening and will listen to this, that I think it was great. And I'm happy to help. So any way I can be of any help to anyone, then we're out there, and we've got links and emails and stuff, and we try to answer all the emails, maybe not within a day, but we try to get to everybody that we can. And again, I hope everybody listening feels better tomorrow than they felt today just simply from listening tonight.
I know I did, so thank you. Well, And thank you for everyone tuning in. Next Tuesday, Sherry New will be our guest to talk about the wonderful advocacy work she has been doing for the CRPS community and to share her personal journey with CRPS. We're going to get personal and talk about the good, the bad, and the ugly concerning CRPS. Well, I wanted to say thank you, Caw Nation, for listening in, and I hope you have a great night.
Listening to Conspiracies Against Wellness with Janelle Elgaway. Join us next week to get in on the conversation. The opinions expressed on this program are those of the host and callers, and not necessarily those of EXG, LLC, its employees, or sponsors. I'm David Schiff.
The Cause Show with Janelle Elgaway is copyright 2017 by EXG LLC. All rights reserved.